Thank you, and thank you to the CCFA for inviting me and for all you to being here when the pool's outside and the pina coladas are outside. So my interest in this topic is from initially doing clinical trials of fecal transplantation in Crohn's disease, and from that grew doing fecal transplantation for patients with IBD who had recurrent C. diff, and then for just a lot of patients with recurrent C. diff. So I'm going to just go over kind of a take on where we currently stand in terms of testing and treatment, particularly as related to our IBD patients. These are my disclosures. So I think it's helpful to start with a case. This is a gentleman who'd had an extensive history of ulcerative colitis, had been doing well on mesalamine, but as often happens, developed a complication, in this case diverticulitis, that required treatment with antibiotics. And after that course, although the diverticulitis resolved, he started to get worsening of his colitis, but what seemed to be a flare-up with worsening symptoms despite an adequate dose of oral mesalamine. Initial testing C. diff was negative by PCR. So I treated him with some prednisone, didn't really get as good a response as I thought I would. And then after 2 weeks or so of prednisone and no much response, repeated the C. diff test, and he comes back PCR positive. And so at that point, I treated him with metronidazole, which would be kind of standard first-line therapy. 5 days of metronidazole, he's still really not getting as well as I think he should be, and do a sigmoidoscopy, which really shows he's active disease. It's really hard to tell, is this active C. diff colitis or active ulcerative colitis or both? And so it raised a couple of questions. In these patients who are patients who've got IBD and ongoing inflammation, the relevance of the PCR testing, and is there one test better than the other? Which antibiotic should we be using? I mean, is flagyl still a go-to agent? Should we go straight to vancomycin in these patients? And when they do flare and get C. diff positive, should we stop their immunosuppression and treat them, or should we continue the immunosuppression, even escalate the immunosuppression and treat the C. diff? And then finally, if these patients do develop recurrent C. diff or refractory C. diff, are fecal transplants a safe and reasonable option in this scenario, and is it any different to doing a fecal transplant in the non-IBD patient? So the first thing I'm going to talk about is the testing. For ID physicians, it's very easy to look at patients who have all these symptoms and say, well, these are the typical symptoms of C. diff-associated diarrhea. And of course, the problem for us is they also overlap with most of the symptoms of an IBD flare. And if you look at the data on hospitalizations, about 7% of patients hospitalized for an IBD flare are found to be C. diff positive. And most of this testing is based on ELISA and more recent years on PCR. The challenge is, PCR is an excellent, extremely sensitive test for your first C. diff infection if you don't have IBD. It's extremely sensitive. It can pick up picograms of genomic material for the toxin, and so it's very, very sensitive. The problem is if you have ongoing IBD and have had a couple of infections, the clinical specificity of is this colonization or is this a new infection causing the symptoms right now is very hard to distinguish. Many centers have found that when they dropped ELISA testing for the toxin and switched to PCR testing for the gene for the toxin, they found they had a doubling of their overall prevalence of PCR positive or C. diff positive patients in their hospitalized setting. And there's some data here looking at the prevalence. This is a large study in 2,500 patients. With IBD, about 5% of patients were positive, whether they use toxin testing by ELISA or by PCR, but in the non-IBD patient population, the prevalence of C. diff positive patients increased quite a lot once they switched to PCR testing. So it's quite a sensitive test, and we need to think about this in terms of what are we measuring in many of these patients. There was a nice study from Athos at Children's 2 years ago where they took archival samples from the freezer that they knew were positive for C. diff, and they looked then in those that were PCR positive, how many of them would have been actually positive by ELISA, by the original test, and only 10% of the PCR positive tests would have been positive by ELISA. Now, there's one or two methodological limitations here potentially, but it certainly suggests that many of these patients who are now testing as PCR positive for C. diff would have been negative by the prior test. And then it comes back to the question, well, are these infected people or are they just colonized people where the C. diff is a kind of an incidental finding? And one way to think about this is to look at bacterial load. So this is a study from the micro literature 2 years ago, looking at the colony-forming units of C. diff, toxin-producing C. diff. And if you look at the different tests in people who are PCR positive, the level of C. diff to be present is much, much lower for the test to be positive, and it's only at much higher levels of bacterial load that the actual ELISA test will turn positive. So many of these have potentially low-level colonization, not active infection that's causing their symptoms or their disease. And in response to this, some groups have introduced two-step testing or doing both tests. So, if PCR is too sensitive, you may do PCR, and then in PCR positive people do an ELISA and look for toxin. And there are pros and cons of both. The other way is to actually do a test like GDH, glutamate dehydrogenase, that tests for the presence of Clostridium species in general to see are they there, and then maybe do a toxin test to look for the toxin. It does, if you do a two-step test using both GDH, for example, and ELISA, it does increase the positive predictive value of that testing mechanism. Where PCR comes into this in terms of trying to reduce the false positives, certainly if you include a toxin test and a PCR test, you may get the people who are truly not just colonized but infected. The challenge is, I know in our institution, most institutions have dropped ELISAs altogether. You can only do the PCR test, and so this may be challenging locally. And there are some data showing that although there's some increase in the costs, you may well reduce the false negatives in terms of clinical specificity that you would otherwise treat with antibiotics. There may be a solution to this. The next step ELISAs are single molecule arrays where there are beta ELISA tests where they can pick up just a single molecule of the toxin, and they're about 1,000 times more sensitive than our traditional ELISAs, but not as sensitive as a PCR test. So it's somewhere in the middle. And this may be a way of finding the people who are not just colonized, but are actively producing toxin, even at a low level that in the past we would have said, well, they may have been missed by an ELISA test. So this is in development, and maybe it's also known as a digital ELISA because you get a quantification of the amount of toxin present, like we showed for the curves of the amount of bacteria present, that you could say, okay, above this level, these are truly infected people. Below this level, these may well just be colonized. So this is something to look out for as it goes through the development process. So assuming you've decided that your patient, by whatever means, truly has a C. diff infection and not just colonized with IBD, what's the best antibiotic to use? Unfortunately for us, almost all our IBD patients are excluded from controlled trials of antibiotics in C. diff infection. And so what we really have to go on is some retrospective cohort studies looking at various kind of post hoc outcomes. This was one looking at over 100 patients hospitalized with IBD. Most of them end up getting vancomycin after metronidazole. It's not controlled for disease severity, but what they did find was that patients who got metronidazole had a much higher readmission rate over 30 days than the patients who got vancomycin after metronidazole. And this certainly suggests that in the IBD patients, most of whom would meet the ID criteria for what would be called a severe C. diff infection, that really vancomycin is the way to go. The other thing worth noting is that in the last couple of years, there's been an incremental decline, or other way, an incremental increase in the failure rate with metronidazole in anything above mild C. diff infections. And it used to be as low as 5%, more recent studies it's as high as 20%. And so since most of our IBD patients, just by their symptoms, would meet the criteria for at least moderate severe C. diff infection, then really vancomycin would be the way to go for all but the very mildest cases. And so to put that in context, this would be a kind of a proposed algorithm. Again, very mild patients, outpatients with IBD with a very mild increase in symptoms who are C. diff positive, I think Flagyl is a reasonable option. But anything more than that, they should all be getting vancomycin as their first-line therapy. And then following the ID route in terms of more severe disease, getting higher doses of vancomycin. What to do with recurrent infections? I think a typical prolonged taper will be the way to go, because it seems to work certainly in anecdotal experience in our IBD patients just as well. I think for those that have recurrent C. diff infection where they're PCR positive, the real challenge is there, are we treating with flare-ups in a colonized population versus truly recurrent active C. diff infections? And I certainly have my bar for doing fecal transplants in these patients has dropped considerably over the last 2 or 3 years. Obviously, A, because of a personal interest, but also because I think if you really want to squeeze out the niche that C. diff occupies in the microbiome, a fecal transplant is certainly the most effective way we have right now to do that. And so, when we think about, well, let's treat all the severe people with this therapy, again, the problem is the criteria for severe CD infections, Clostridium difficile infections, look very much like severe IBD infections. Even if you look at objective markers like albumin, creatinine, and so forth, they have a lot of overlap between the two. So many of our patients who are hospitalized meet criteria for both and would be considered a severe C. diff infection. As I mentioned, endoscopy is pretty useless in this regard in terms of determining, is your patient with an IBD flare-up who's PCR positive, is it the C. diff or is it the IBD that's really worsening things? Only 13% actually have pseudomembranes, and I think I can tell you from my personal experience using fecal transplants in these patients, we very rarely see patients with the classical pseudomembranes, even though they have recurrent C. diff or refractory C. diff when you actually scope them to do the fecal transplant. So the other question that comes up is, well, you've got your patient who's flaring, they're PCR positive, you're treating their C. diff infection. What about their prednisone, or what about their anti-TNF that they're on? Should you drop it, increase it, what to do? And not surprisingly, most IBD experts are very divided on what to do here. ECHO did a small study recently where they looked at about 155 patients hospitalized. And they looked then for risk factors for either death, colectomy, megacolon, or shock within that population. And they reported if you were on more than 2 immunosuppressants during therapy, that was a risk factor for those adverse outcomes. Now, I think it's hard to draw many conclusions for that. This may just be a surrogate marker of severity of disease rather than the infection per se, but it was an interesting observation nonetheless. So what about our case? So this guy wasn't really responding, switched him from metronidazole to vancomycin. He had many criteria both for an IBD patient and for a C. diff patient for severe disease, low albumin, elevated age, inflammatory markers. Despite the vancomycin, still was not improving. And so we bit the bullet and said, you know what, we've treated your C. diff adequately, but your disease is still flaring. You've got endoscopic evidence of activity. We gave him an infliximab infusion, and gradually this was able to control the symptoms, reduce inflammatory markers, and in parallel then gradually tapered him off the vancomycin and got him back into remission. So I did mention fecal transplantation, and so this has become, as many of you know, the kind of standard of care now for at least recurrent C. diff infections and in case series for refractory C. diff infections. If you look at this nice kind of retrospective case series by Colleen Kelly et al. Last year, they looked at all the patients they could put together who got a fecal transplant for C. diff and happened to have IBD. And their reported cure rate was very similar to the randomized controlled trial in the New England Journal 2 years ago, which is about 90% cure rate in preventing recurrent infections after a single FMT in these patients who also had IBD. One of the things when we started our Crohn's trial 2 years ago, people said is you're going to actually make their IBD worse. And reassuringly, in this study, there were only 4 patients whose IBD got worse after the fecal transplant out of 36. So not a major safety signal, I'd say. And also, very importantly, many of these patients were on biologics, immunosuppressants. There were no serious infections after the fecal transplant. And so I think that was very reassuring to say, if your patient needs a fecal transplant for C. diff and has IBD, there should not be a concern about withholding it because you're concerned about them being immunosuppressed and having infections and so forth. So that's all I have to add. I'll take questions if you have any from the floor.